Here we are. Welcome to the Deschutes County Board of Commissioners meeting. This is 9 a.m. Wednesday, October 8th, 2025. First item on the agenda is Pledge of Allegiance. Please join me.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
At this time is citizen input for items not on the agenda. Mr. Ron Bozell. Rondo, you're up. Yeah, Ron first. Yeah. That's the first paper I got, so we'll go with that.
I just wanted to hear you say my name twice. Morning. I just thought I'd drop a real quick thought bomb that I had recently as we've been creating precincts. The precinct committee meetings have been happening and we've been making decisions. I only went to the first one so far, but I have some pretty good confidence in those people that we've chosen, that you've chosen for that committee. I want to throw a little curveball because we want this county better represented. So I think that we can agree mostly that the homeless in this community, in this county, are probably the most unrepresented people in this county. So I would like you to consider creating a precinct representing the homeless. Thank you.
Thank you very much. At this time, Mr. Bill Boos and Jim Pfister together on an item they're bringing to us. Yeah.
All right. For the record, my name is Jim Pfister, and I'm the Managing Board Chair for the Sun River Service District. Chief.
Yes, and I'm Bill Boos, Fire Chief for Sun River Fire Department.
So we just wanted to take a second or a moment of your time to also publicly thank Kim Riley for the great work that she did in working with our Sun River Fire on the recent union labor negotiation that was done. What is our local? I can never remember.
The local 42, I can't remember either.
Kim will know.
I think.
Oh,
Yeah, 4262, local 4262. Sorry, I'm used to Bend Fire Department's local.
The local 4260, we just, we were doing our negotiations internally, but as we needed to get into some legal niceties, we used our legal representation that the county offers us for a fee, and took advantage of that. And Kim did a excellent job in terms of helping us do a fair and balanced negotiation that was a win-win for both sides. So we did want to just take a minute, I got 12 seconds left, of time to publicly thank Kim. We have a letter of recognition for her, as well as a fire department challenge coin that we will present. And I will actually forward that letter to all of you later today. I didn't get the final copy in time to send it this morning.
Great. Well, thank you very much. So this is our service district partnership, creating fire and police services in Sun River. Thank you very much for the recognition. Congratulations, Kim, for being recognized. Here we go.
And we did it in public comments, so you wouldn't see it on the agenda, Kim.
Yeah, there you go. Perfect.
And you get 3 minutes for public comment here, so, you know.
No, I want to be recognized.
Trying to be efficient.
All right.
There you go. Some recognition, partnership.
we can't take a picture, can we?
Yes, we can.
Big,
Photo opportunity.
yeah.
Somebody's got a camera.
This is great.
It was outstanding.
Yeah, I know that. I stepped by her. I know she's outstanding. Yeah,
There it is.
yes. Come, get down there.
Oops.
Like a surprise birthday party.
Yeah. Well,
Are we gonna get into it?
Yeah.
Our governing board, please.
Yes. Congratulations.
All right, 3, 2. Got it.
And that home for the family.
Thank you.
I had to sleep right sort of there.
Yeah. How was that? Oh, yeah. I almost tripped up on that. That was a great, let's see, move.
At this time, Commissioner announcements, anything today?
Well,
You come up with something?
it'll come later.
Okay, yeah, we have the end of the meeting also. So at this time, consent agenda, 4 items today. 1 set of minutes.
Second.
It's been moved and seconded. Any other discussion?
Well, I would just, in support of one of these consent agenda items, I'd like to express appreciation again for our partnership with the Bend Lapine Schools on the Healthy Schools program, which has already demonstrated improvements in youth mental health, in the last 3 years, and look forward to more in-depth analysis and report in the coming year.
And it talks about by the end of this year for a report.
Yeah.
And that's actually what I have a other memo on. We're, according to this, it's $578,000. And when I met with Holly, our new medical department head, director, I talked to her about the fact that I'm really hoping some of the schools, or at least she suggested possibly a pilot program with one of the schools so that our kids are no longer served low-fat chocolate milk. It's loaded with sugar, and they actually make healthy, more of a healthy menu. So she suggested maybe we could negotiate with the school district and have them do a pilot in one of the schools. So I'm hoping we can incorporate that. If you see what they serve in Canada, I was in Canada a year ago, and oh my gosh, it is amazing. The things that are not allowed to be sold in Canada, and yet they're in products in America. So I brought that up earlier a year ago, and now I'm bringing it back. So I'm hoping we can make that change, get our kids healthier.
So these are all comments about our partnership with the Bend Lapine School
Right.
District Continue Healthy Schools program.
Well, if they're going to be healthy, they need to eat healthy. And Holly actually acknowledged she makes her daughter's lunch every day. And I said, well, the important thing is, does your daughter eat it? And she thought she did. So,
did.
how to get our kids healthy.
Okay, any other discussion? Seeing none, Commissioner Dare,
Yes.
Commissioner Chang,
Yes.
and Chair will vote yes. At this time, item number 5, consideration of a collective bargaining agreement with Deschutes County and the Deschutes County Sheriff Employee Association. Thank you for joining us today.
Morning.
Morning. Morning, Commissioners. I'll lead us off with introductions. Whitney Hale, Deputy County Administrator.
Hi, Rupert, Deschutes County Sheriff.
Rob Lindsay, Deputy Sheriff, Vice President of the Association.
Mhm.
And we're here today for consideration of contract number 2025-968, which is the collective bargaining agreement between Deschutes County and the Deschutes County Sheriff's Employees Association. I'm happy to walk through a few of the high-level changes, but before I do, I'm going to turn it over to the sheriff to talk a little bit about the process that got us here today.
Great, thank you.
Good morning. Thank you for your time. We met recently. I asked for a little bit of grace in working with the union. We've been trying to get this collective bargaining agreement done all year. And so I appreciate the grace when the commissioners heard us about a month ago. We move forward, and thank you to the support from our union and our union leadership. They have agreed to what was presented to them. And this has been a tremendous group effort, not only from the county, but also from our union, the Sheriff's Office command team. Captain Sundberg was involved also. So this was a great demonstration of what we can do as a team. And I just thank everybody involved.
Great, thank you. Any
I
comments?
just want to say thank you very much for consideration of this resolution. It was hard fought, and we thank you very much for considering a 1-year contract to get us through so we can start new negotiations moving forward in a great, peaceful manner. And thank you to the sheriff and to everybody involved so that we could come to a resolution that was good for everyone.
Yeah, well, and I always support a very business-like atmosphere. The words we use matter. So as I say, let's hopefully don't think of it as a fight, but it's just a partnership. It's the business relationship. It's the inflationary environment. It's the benefits, just the big picture, being business-like on both sides of the equation. So thank you, though. It's great to be here today. So yeah, let's talk a little bit about the specifics.
Yep. As was mentioned, this is a one-year contract, and there is not a ton of change within this one-year contract. The things I would highlight for the board and those watching today is that within this agreement, we have a cost of living adjustment that matches CPI within a range of 1% to 4%. We have some small adjustments for K-9 and FTO premium pay and some wage adjustments for staff that were identified to need them for classifications that were identified as needing some adjustment. This contract also includes some higher level administrative modifications to the tuition reimbursement program, the time management leave program, and the military leave program. And the county's bargaining team, the management team, is recommending approval from the board on this contract. I want to specifically thank our controller, Jana Kane, and senior assistant legal counsel, Chris Bell, who are sitting behind me, for all of their work in supporting us and making sure that we had the facts we need. Chris, we don't have a challenge coin for you today, but we really do appreciate your steadfast support through this process. So with that, staff would be happy to answer any questions that the board may have, but we would recommend approval of this contract.
Great, thank you. Thoughts?
Well, I appreciate the association and the sheriff's office leadership working through this process to get us to this 1-year contract. I want to recognize that there are a lot of things afoot in the state and local level in this next year, which will drive the way that the next negotiation takes place, which, I mean, if it's a 1-year term, literally we're starting negotiations like tomorrow. But recognizing that those, that there are a lot of uncertainties right now, question marks that need to resolve. I think that this is a great solution, a great answer at this point in time to the need to continue to have a solid contract that people are working under that works for both the sheriff's office and the employees. So thank you.
Commissioner Derrick.
Thank you.
I'm just wondering, are you already working on next year? When are we doing that?
We are, yes. We're working, some of this, as you know, we're working through, once we get this approved, hopefully today.
Hopefully,
Hopefully.
that's the key word.
It is. We're gonna start working as soon as possible on the next one. And, the members, I appreciate the commissioners putting me in this position. I really do. The working relationship that I have with the folks that I work with has always been incredible. And it speaks volumes to them at the allowing or just giving me the trust, saying we trust you, we trust the command staff. And so I know that relationship that got us here today will help us in next year's negotiations as well. So I'm looking forward to that.
Great.
And thank you for your department, what you do. And, when you see law enforcement losing their life across our nation, it always breaks my heart. So I appreciate what you're doing. And the responsiveness is really to be commended, because everyone that I ever have to reach out to about a speeding car or a barking dog or something, people are so incredibly responsive. And that's really, it's a great relationship to have.
Yes, ma'am.
So thank you.
Thank you.
Well, and today's October 8th. We're backing ourselves up to July 1st, 2025 for this agreement, but it's going to get us through this next year. Great partnership, just a sense of service, the integrity of the office. And then, let's take a little breather, but then we'll be back at it again. So I want to thank the professionalism on both sides to get us to this point for sure. Any other thoughts, or is there a motion?
Move approval of contract number 2025968, a collective bargaining agreement between Deschutes County and the Deschutes County Sheriff's Employees Association.
Second.
Is there any other discussion? Seeing none, Commissioner Dare, Commissioner Chang.
Yes.
And Chair will vote yes. Thank you very much. As I say, this is the beginning of the next one, but we'll get there as
Ooh.
partners.
Thank you very much. I appreciate it.
Thank you very much. We greatly appreciate it.
Thank you.
One last thing I would like to say is, in prior cycles, we have seen not as great coordination between the sheriff's office leadership and county admin staff, county legal counsel, in the negotiation of these contracts. And I really appreciate that we have a really unified effort, with the association, with all the different departments of the county in moving forward with this contract and with future contracts. So thank you all very much for that.
Can I add one more thing?
Sure.
Yeah.
I don't know who would be here today if it wasn't for Sheriff Rupert and Captain Sundberg. They really made sure that we could get something done to support everyone. Just want to make sure everybody was aware.
Thank you so much.
Thank you.
Thank you.
Okay. Have a great day.
Do we get a picture too?
Sure, let's get a photo. Let's get a photo. Today's photo day.
were gonna say that. Are my heels. Oh, goodness.
You can stand next to me. We'll together.
We stand in front of the logo.
Yeah, there we go.
We stand in front of the logo.
Yeah. Yes, see on my baby because.
Okay, now there we go.
Jordan. All right. 3, 2. Got it.
Thank
you, sir.
Yeah, see you. We're gonna start with the next one.
Oh,
Thanks, sir.
Thank you.
Okay, careful, Dave. We might take a photo after this one.
Not take a photo with you.
Item number 6, public hearing consideration approving annexation into the Redmond Fire and Rescue District.
Thank you, Commissioners. Dave Doyle, County Council. This is a time for a public hearing to consider Order 2025-044, which will approve a 54-acre annexation into the Redmond Fire and Rescue District. All the associated staff, including the fire district, have all reviewed the petition and approved it. And as indicated, this would be the time to open a public hearing and see if there's any comments or testimony.
Thank you very much. At this time, this is opening a public hearing for consideration of an order approving annexation of 54 acres into the on Northwest Oak Avenue into Redmond Fire and Rescue District. Is there anyone to speak on this matter? Is there anyone remote? Okay, seeing none, we'll close the public hearing on this matter. So yeah, this is the end of a process. Everybody else has already approved it. So any discussion or is there a motion?
I'll move approval of order number 2025-044, approving the annexation of 54 acres on Northwest Oak Avenue into the Redmond Fire and Rescue District.
I'll second the motion.
Okay. Any other discussion? Seeing none, Commissioner Chang,
Yes.
Commissioner Adair,
Yes.
and Chair will vote yes.
Thank you.
Thank you. At this time, item number 7, Bend Fire and Rescue proposed contract with Alfalfa Fire District. This is for basic life support emergency transport services.
Hello, Commissioners. I'm Tom Kuhn from Deschutes County Public Health, and I have with me today a couple guests.
Good morning. I'm Drew Norris. I'm our EMS chief for Bend Fire and Rescue.
Good morning, Commissioners. I'm Chad LaValle, Fire Chief, Alfalfa Fire District.
And we are here this morning to request approval of a contract between Bend Fire and Rescue and Alfalfa Fire District for the provision of basic life support emergency transport services within the boundaries of Alfalfa Fire District's Fire Protection Area, which is located entirely within Bend Fire and Rescue's ambulance service area. And this is allowable under Deschutes County Code 8.30.07, which allows subcontracting of services by our licensed franchisees. This has happened one time in the past, so this has been done before. But we're definitely happy to have them engage in this contract to really improve response times and efficiency. So I'll turn it over to Drew and Chad for more details about the contract.
Thank you.
Yeah, good morning, commissioners. Thank you for your consideration on this IGA. This is kind of a unique situation in the sense that it's Bend Fire and Rescue's ambulance service area, which is pretty broad. And Alfalfa Fire District has their fire district within our ASA. We have collaborated together on calls for years. We have the same physician advisor. They come to our case reviews. So this is nothing new besides the transport piece for basic life support care to be able to transport to the hospital, which gives them better coverage and support in their area, while also leaving resources in Bend where it's a bit busier. We're talking about 20 to 30 calls a year in this area, so it's small, but it does help the constituents of Alfalfa to be able to get that care they need earlier, and we're still there as backup if they need us. Happy to answer any questions that you guys may have.
Well, Chad, any thoughts on, tell me about this new rig you're going to put in service.
Oh, so we basically what we looked at is we looked at, our constituents and the needs of our district as we grow. As you guys know, the growth potential in Alfalfa is pretty stagnant right at the moment. So what we looked at is we looked at ways to increase revenue. Like I said, it's 20, 30 calls a year, which doesn't get much, but in the big picture, it's little steps towards a big picture. We want to make sure that our constituents are taken care of. With Bend increasingly getting busier, we've seen our call times, not dramatically, but we've seen them get a little bit longer. And so basically what we did is we looked at ways to help our constituents as we move forward. Like Drew said, to speed up the care, get them to the hospital, and then have Bend Fire back us up when we need it.
So a couple thoughts. This is a basic life support ambulance dispatch. Somebody will call, 911 will send out. Is this fully staffed full-time or is this on-call?
This will be staffed full-time. So we are working, we have just put in permits to add onto our building. We have we just developed a student program. We brought on more folks. So we're looking at probably by the end of October, we should be up and running 24/7.
And then you have the rig already?
Yes, sir.
And is
it's already sitting in our bays. It's already, we got the ambulance on a grant. We, put everything together. We put aside some department funds to outfit it. It's basically sitting in our apparatus bays getting ready. It's basically ready for this agreement to be signed. The only other outstanding thing we have to do is send this agreement to OHA, have them come in, do their inspection, get it licensed, then it'll be ready to go.
And say, we haven't talked about this before, and this is our public meeting on this subject, but La Pine Fire having a hard time with their reimbursements, and the cost of every run is probably not even covering its costs. We just saw in the news today up in Jefferson County how they're going to have financial trouble. So, what's the business case here that's going to
the business side of things is most of our staff is all volunteers. We've developed a volunteer program that will span 24 hours a day, 7 days a week. So with that volunteer program, we're not paying out a lot. When you look at 20 to 30 calls generating, even if we generate 60% of the revenue return on those calls, it generates at least something. As you guys know here, a little while back, you guys had given us a loan to help out with the fire station. We're looking at ways to increase revenue in any way, shape, or form to help start covering costs and repay things back. As you know, when that loan is finished, that'll free up more funds for us to be able to add more staffing and more things. So we're just kind of looking at, the revenue, obviously, the outlook for any EMS agency isn't great right now. But for us, if we can at least generate $3,000 a year, it's something. It's moving in the right direction.
Great. Yeah.
So even though the reimbursement rates for medical transport aren't great because you're using volunteers, it works out.
It does. Yeah, we've done the math on this. We've also reached out, or actually we didn't reach out. LifeFlight reached out to us to, potentially take some of the BLS transports from Bend and Redmond agencies. Those generate, I think, a 90 to 100% revenue rate. So those, like I said, any revenue that we can generate is building us in the right direction. And with the volunteer base that we've built, we're not paying out anything. And what we're looking for is to generate enough revenue, hopefully in the next 2 to 3 years to then, systematically hire on. We're looking at going out for a levy in May for staffing. So it's kind of, building that base up to where, even the climate that we have in the EMS world right now, it's really, like I said, is a step in the right direction.
And within your volunteer, so you talked about, the vehicle, the wing of the building. Within your volunteer pool, do you have this full set of skills and training?
So within our volunteer base, everybody is at least an EMR. We have 9 EMTs and we have 2 paramedics that are volunteering with us 5 days a week. Not that we're going to do any ALS stuff, but we have them to ride along as a BLS provider.
Chad, remind me, how long was your loan for?
I think we have 3 years left on the station loan. And then I think we had that extended to, 2 years on yours. And I'd have to look back at the paperwork, but I think we're about 5 years out.
That's great. No, I really appreciate, and the fact that you have the volunteers really says a lot about your community, because I know that Cloverdale really has struggled for volunteers, for people that step up and really do make a difference.
Yeah, and it's in the as you guys know, the volunteer side of the fire service is dwindling, and so we're pretty fortunate that we have the volunteers we have that put in the time and the effort to make sure that our constituents are taken care of in our fire district.
And you are what, 30 minutes to St. Charles?
We're roughly about 20 minutes to St.
20?
Charles.
Okay.
Yeah.
Depends how fast you're going.
It depends on which side of the district you come
Know
from.
what's legal and what's not.
Yeah,
Yes.
yeah. And it depends on what side of the district you come from. So
Okay. All right. Great. No, I'm so glad that you have all worked together on this. Thanks, Tom.
Can I ask, so what kind of emergency medical services are you currently providing? So you have EMRs, you have paramedics. So currently, are you going to emergencies, stabilizing people, and then waiting for Bend Fire to come in with the ambulance? That's kind of what's happening right now. Okay. And this would extend on that, allow you to do the transports as needed.
as needed. Yes, sir.
Okay. Okay.
Is there a scenario with advanced life support? I mean, yeah, just help me as a layperson understand the different, because I just know the terminology.
Yeah, so
Go ahead, Drew.
I'm just thinking somebody calls and then the
the way-
dispatch determines the severity of this incident.
Exactly. So somebody would call 911 for, say, a heart attack, and they'd give the signs of a heart attack. And that's an advanced life support call. And so that you can start IV, give medications, do a lot of those advanced skills, where for an EMT, if you call for maybe a broken ankle or something of that nature, it's not as life-threatening. Those are the calls that Alfalfa would be taking currently. So they could get a call like that. Well, then they maybe need medication, and they can call us and we can come out and help them, or rendezvous in the middle and have them meet us halfway. And then we can either put one of our paramedics on their rig, or they can jump into ours. We can continue treatment and then take them to the hospital.
Okay, good. Yeah. So there may be severity of an incident, real-time response, but you'll be able to roll.
Yeah, long ways out. We could ask for an ALS intercept from Bend, and like Drew said, meet them in the middle, have their paramedic jump on our ambulance, and we can continue
good.
heading to the hospital.
Good. Another question for Tom. So we, on similar kinds of issues, we have relied pretty heavily on the advice of the ASA committee in the past. So I'm curious whether this particular proposal has been before the ASA committee, or is this, two fire districts just kind of figuring something out?
I've shared all the information about this with the entire ASA committee via email to ask if there's any comments or feedback. Everyone's supportive of this, even though this type of situation doesn't occur often. As I said, this is only the second time this has happened. And I've not heard of other franchises now wishing to do this as well.
Right.
So
The collective wisdom of the ASA committee says this makes sense.
yeah, and I have to say that as I've been working with the ASA committee a lot over the past year on revising our county code and plan, which is getting close to being finished. It's been a very long process. I've just observed how well our franchises work together and get along. I've spoken with ASA administrators from other parts of the state, and they often have many conflicts and territorial issues. And I really don't have any problems at all. Just very minor stuff comes across my desk. So I think we're very fortunate here.
Central Oregon way.
Yeah.
Yeah.
Wonderful.
Right.
So good discussion. Is there anything else? The agreement's been presented. Or is there a motion?
Move to authorize the Bend Fire and Rescue to enter into a contract with Alfalfa Fire District for the provisions of basic life support emergency transport services within the boundaries of the Alfalfa Fire District Fire Protection Area.
Second.
Been moved and seconded. Any other discussion? Seeing none, Commissioner Dare,
Yes.
Commissioner Chang,
Yes.
and Chair will vote yes also. Thank you very much. Good partnership starting here. Basic Light Support Services out in Alfalfa.
I appreciate it. Thank you.
Such an excellent idea. I am so glad that you brought it to us, and thank you, Tom, for your leadership there, because this is really what you do. It gives your community a greater feeling of the support. So,
Absolutely.
yeah. So thank you,
Thank you.
all of you.
I hope this works for both of your districts and results in much, improved, faster service for your constituents.
Sir. Thanks, commissioners.
Thank you.
Thank you.
Item number 8, respiratory season update. We're bringing in the professionals today. I think we had asked for this, but it's just kind of the big picture. What does it look like? We hear in the news about access to vaccines, policies about vaccines, but good to see everybody.
See you.
You.
Thank you for having us. For the record, I'm Heather Keisner, Public Health Director for Deschutes County. And yes, first, I just wanted to thank you for inviting us to come and speak on respiratory season. I think this is something we actually would like to do every year in the fall. I think it's important information for our community to keep ourselves safe and our loved ones. I'm actually just up here to introduce our two subject matter experts, because I think maybe one has not been here before and the other one, and maybe it's been a while. So I want to introduce Sarah Van Meter, who is our immunization coordinator and nurse. She's been with the county for 2 years. She really is a trusted source of information for our families, for our schools, here in the community. So happy to have her here today to talk more kind of about vaccines and respiratory season. And then we have Dr. Richard Fawcett, who is our longstanding health officer. He's been with the county, goodness, I think since 2007 in different capacities. And we're really lucky to have him as our health officer. He's also an infectious disease specialist in our community and really is a source of information for many of our providers and community members. So I'm going to turn it over to them.
And one other thought, this is kind of the path of the population health, right? Because there's acute individual situations, but this is population health. This is for everybody. Best practices, best information that we can provide. So thank you very much for joining us today.
Thank you.
Great. Thank you for having us come and do this overview. We'll try to stay on pace. I don't know if you can hear me okay, but
I might bring it a little closer.
good. Okay, great. And you can see the slides. Yeah, I think that's better. Okay, great. I'm Rich Fawcett. I'm an infectious disease physician here. I do have 4 other partners in the area now that do a terrific job. So I don't have to be 5 places at once. So, but like Commissioner DeBone mentioned, that's our clinical practice and what we do in taking care of individual patients. And that's a little bit different than my role as the public health officer here for Deschutes County. So we're just going to go through an overview on what we call the respiratory season, and we're referring to common viral illnesses, usually that cause respiratory symptoms, typically during the colder months, so fall, late fall, winter, and early spring. Next slide.
Oh, yeah, probably the up or down or left or right.
Okay,
Yeah.
thanks, Rhonda. Yeah. Okay. So these are the 3 viruses that we're concerned about this time of year, and we just kind of put them up there as topics with the kind of the sort of lingo and what we're talking about medically. So flu, we're referring to influenza A and influenza B. And RSV is another viral respiratory illness, a little bit more common in the pediatric age range and typically more severe in infants. And that stands for respiratory syncytial virus. And COVID-19, we've become familiar with that. This is the illness that's caused by the virus SARS-CoV-2. This is severe acute respiratory syndrome coronavirus 2. And it's very similar to the original severe acute respiratory virus syndrome 1, which we know as SARS, that happened in 2003. Thank you, Heather. So I wanted to give an overview. I think we went 2 slides and we need to back up one. There we go. Okay, great. So this is just a time per incidence of disease graph that is looking at the last respiratory season, fall, winter. And it's on the x-axis, it's the time, so it's by weeks, and it kind of starts in the late summer there on the left, week 39. So week 1 there, of course, is January, first week of January. So again, this is looking at the 24-25 season. And I'll just point out that the blue graph there, the blue line is influenza, the orange is RSV, respiratory syncytial virus, and then COVID-19 is the red line. So I just want to point out, and this may be common knowledge to a lot of us, but this is data that we have locally. Again, this is looking at the PCR test positivity rates for our region, for our main labs in the area. So it's not all tests, it's not rapid antigen tests, but a lot of the cases of influenza A, B, RSV, and for COVID-19 are diagnosed by these PCR nasal swab tests that you're probably familiar with. So this is local data, and it's from last season, 24-25. So looking at influenza, the blue line.
Question.
Yeah.
So when you said regional, so this is showing data from the Tri-County area, or even more localized, or
right. It is regional. It's looking at the laboratories. So, for instance, we're looking at St. Charles, Summit, COPA, and they do have some clinics that are outside. A lot of it, it's Deschutes County heavy. I admit that. So. It doesn't include everything, but I think it gives us a good sampling of local activity.
Kind of the medical service area.
Yeah, so we years ago started doing our own respiratory season reports, and part of that was because at OHA level, when they look at respiratory, they were only looking kind of more in the Portland central area, and our local providers were like, but what's happening here? So we started, so it is a Central Oregon, and we have a Central Oregon epidemiologist who does this.
And we have a good partnership with our labs that give us data, especially during the fall and winter and spring. But we look at this data all year long. So again, just kind of focusing in on these graphs. The blue there is influenza from the last season, and you can see that it really started to peak again. So that top number is 29% of all the PCR tests at that time were positive for influenza A or B. And that was mid to late December. And we had really pretty sustained activity through the winter time, all the way with a peak of 17% in mid-March. That's a fairly typical season for Central Oregon. That influenza activity seems to peak February, maybe late January. That's not unusual. RSV is similar in some locales. Even in Oregon, RSV activity will be a little sooner than influenza, but typically it starts in the fall, November, December, and lasts through February, March. And so that's the orange graph for our local data. Pretty similar, not as much activity as with influenza, but still a nice kind of peak there around week 7 or 8. Now, COVID-19 is the red line down below. This has a different shape to the curve in terms of it's circulation in the community, its seasonality, if you will. We really don't see quite the same activity during the winter, fall, spring months like we do with influenza and RSV. However, we see resurgences and spiking of activity with COVID-19 throughout the year. And I think what we've been seeing is shown in this graph here. This is even last year's data. Last summer, towards the middle or end of August, we start to see increased activity. So you're seeing that red line about 16% August 31st, which was kind of sustained through September, November, but it does seem to taper off. And you can see that by week 1, it was much lower. So it is a recurrent community viral infection with respiratory symptoms, but not as much, at least the last few years in the wintertime, although we have seen wintertime spikes of COVID-19. Next slide.
Question. So for a PCR swab test, basically one test, are you testing for all 3 of these?
Typically, we are. It depends on the lab itself. St. Charles often does group those 3 together for, I guess, influenza A, B, RSV, and COVID-19. Yeah.
Thank you.
Okay. Yeah. So I just wanted to briefly point out, this is influenza graph looking at the last 3 years, but you can see that a typical year for influenza, I think, is illustrated by last season, 24-25, and the season before also sort of shows that late fall, winter, early spring surge or increased activity. Next slide. RSV, same thing. Again, in the red, our last season that I just spoke about. The season before that, 23-24, a little bit earlier in the season where in November we started seeing increased activity, but pretty typical. I didn't go into the 22-23. That was a different season for everything, especially for influenza that happened earlier, maybe having to do with the masking that we had the season before. There's a lot of theories about that, but that was an atypical season. The typical pattern is better represented by 24-25 and 23-24. Next slide. This is COVID-19. I'll speak about this a little bit later, but again, when you look at the colder months, weeks 51, 1, 3, middle of January, February, you see a lower activity, especially last season. That red dot there with COVID-19 really was quieter during the winter months and then seems to rise during the summer, late summer and fall. Next slide. So now we'll go into talking briefly about the vaccines for each of these 3 viruses, and I'll turn it over to Sarah Van Meter.
Before we leave the epidemiology, I know that there's some data that's collected from wastewater. Does that complement or kind of tell a different story than the data you have from these PCR tests?
I think that it parallels the data we get from the local laboratories fairly well. One of the hopes is that maybe we'd see a spike in wastewater signal for these viruses a little sooner than we might see out in the community. But I think in general, it parallels it pretty well.
That's good to know.
So as we head into the more vaccine-focused part of our presentation, I want to note that there's been no major changes to the actual respiratory season vaccines themselves. And now as we look at the influenza vaccine recommendations, for appropriate age and timing, I want to point out that all children 6 months and older are eligible to receive a flu vaccine, and that adults over the age of 65 are preferentially recommended to receive the high-dose influenza vaccine. As usual, it's recommended that you receive your flu vaccine in September or October, but we do continue to administer vaccine if influenza is still circulating in the community. Next slide, please. Next slide. Thank you. RSV immunization. RSV was approved for use by the FDA in May of 2023, so we're heading into our 3rd season of its use. Infants younger than 8 months and children 8 to 19 months with risk factors may receive RSV monoclonal antibodies if their mothers do not receive RSV immunization during pregnancy. Studies have already shown that vaccinating pregnant women against RSV has led to a 72% drop in hospitalization of newborns with severe lung infections. For adults 75 and older, I want to point out, as well as those between the ages of 50 to 74 years of age living with risk factors, should receive the RSV immunization. And at this time, it's only a one lifetime dose. Next slide, please. Getting back, I want to touch on RSV monoclonal antibodies for infants for a moment because they are different from the RSV immunization that we use on adults. They're a type of passive immunization therapy, which means they provide antibodies directly and proactively. This protection holds the infant through at least 5 months. So RSV monoclonal antibodies should be given as close to RSV season as possible, typically between October and March. But I do want to point out that Oregon's RSV season for 2024-25 began on December 21st of last year. Next slide, please.
So it says 24 then?
I'm sorry?
Well, you said the RSV season for 24-25 began on December 21st of this.
Of 2024, excuse me.
Yeah.
Yeah, typo.
I was like going, well, we haven't had that yet.
No.
Dicty, just
Yeah.
I know, I'm going like,
2 months.
hey,
No.
caught it, so.
Typo, thank you. All right. Now let's talk a little bit about the COVID vaccine. Dr. Fawcett, did you want to go back over this slide just to point out?
Yeah, I spoke about this before, but just, there is a recurrent predictability for COVID-19 over the last 3 years. So this is pretty good data. And again, looking at the increasing incidence locally of test positivity of COVID-19 as we get out to weeks 27, 28. So we're into the summertime, maybe late summer. But I also wanted to just point out the 23-24 season, the blue, that we still had pretty good activity. There's about week 2 or 3, a peak of about 13 or so percent during, the beginning of January. So we definitely do see circulation, transmission of COVID-19 during the winter months as well. But just to point out that, it's not quite the same predictability in terms of the other respiratory viruses in the fall and winter. Next slide. So just to talk a little bit about the COVID-19 vaccines, I think we're familiar with the companies that make the mRNA vaccines that many of us have received. And I've listed down below the available vaccines for the season, but up at the top, the boosters, both for Moderna and for Pfizer, do include targeting against these Omicron subvariants. So JN1 is a fairly common subvariant, and I believe that was in the booster for last fall as well. Also, they've added the LP8.1 subvariant into the booster as well. So in terms of the past experience with mRNA vaccines or COVID vaccines in general, that the larger studies, some of them are very large studies, show protectiveness or effectiveness against, in particular, more severe COVID-19 disease. So in prevention of emergency room visits, urgent care visits, and in prevention of hospitalization. Some of the larger studies quote about 30 to 60% protection. And again, the higher numbers tend to be against hospitalization and severe complications. However, there have been large studies that have shown fairly good protection against milder illness. Some of that is in adults 18 and older across the boards with about a 33% protectiveness for preventing urgent care or emergency room visits and not for hospitalization. To talk briefly about the vaccines on the market, Pfizer's mRNA vaccine, the trade name Comirnaty, is still out there. It's a little bit different because it includes that protection against the LP8.1 subvariant, but otherwise very similar to what we had last year. Moderna, their booster, still Spikevax, is very similar, but again, it adds that extra subvariant protection. There is a new Moderna mRNA vaccine out just recently approved called mNEX Spike. It's very, very similar. It's only approved in people that have been vaccinated previously, so it's a little bit different. You can't use that as your initial COVID-19 vaccine. Then Novavax has put out Nuvaxovid, but only approved for those 12 years and older.
All right, so as we move on to talk about the who and when, or rather the timing of the COVID vaccine, I'm just going to simplify things from the start by saying that the recommendations are very similar to previous years' recommendations. It just took us longer to get to this point. Even as recently as 2 days ago, CDC approval was made, and I had to reconfigure this slide. So if you see in the upper left-hand corner, CDC and ACIP decided that the criteria should be based on individual-based and shared clinical decision-making. But we'll talk about more on that in a moment, how it took so long to get to that decision. But I do want to point out, timing-wise, if you were recently infected, you may delay vaccination for 3 months after the symptoms have started or after receiving a positive test with no symptoms. And also, much like the flu vaccine, the immunity begins to wane after 4 to 6 months. But the COVID vaccine protection against severe disease remains relatively strong. Next slide, please. This is kind of the standard timeline for how vaccine approval is made. It shows that the respiratory season vaccines are normally decided upon behind the scenes, and for a little over a half century, it's proceeded in this manner. As you can see on the far left-hand side of that timeline, they start as early as in February, deciding on the upcoming fall vaccine formulas, which are selected by the FDA. By the spring, the expert advisory groups recommend which versions to use based on the strains. And by the summer, the manufacturers are scaling up their production, and the CDC further defines eligibility. By August, FDA finalizes labeling, ensuring that insurers will confirm coverage. And by fall, we're stocking our shelves and providing vaccine. Next slide, please. This is how the 2025-26 COVID timeline approval went. Back in June of 2025, the prior members of the Advisory Committee on Immunization Practices, otherwise known as the ACIP, were dismissed or replaced, and the COVID vaccine itself did not get voted on. And because there was no guidance from the federal government, on August 6th, American Academy of Pediatrics released their own respiratory season guidance. And then following that, on August 22nd, the American College of Obstetrics and Gynecology released their updated clinical guidance regarding the vaccination during pregnancy against COVID, RSV, and influenza. By August 27th, the FDA approved and updated COVID-19 vaccine recommendations, which they restricted to adults 65 and older, as well as individuals aged 6 months to 64 years with certain high-risk conditions. And this was a significant change from the previous recommendation, which made the vaccine available to everyone over 6 months. Further complicating things is that prescriptions were required in certain states' pharmacies, and Oregon being one of these states, and because the CDC had not yet updated its guidance, therefore the new COVID boosters were not a part of Oregon's pharmacy protocols. This led to, on September 3rd, the West Coast Health Alliance announced its formation, and this comprised of the states of Oregon, Washington, and California, and then a few days later, Hawaii joined. On September 17th, the WCHA released their respiratory virus season immunization recommendations, and this then allowed Oregon's Board of Pharmacy to vaccinate with COVID vaccine without the need of a prescription. Following that, a few days later, the newly formed ACIP recommendations were voted on in favor of allowing shared clinical decision-making for the COVID-19 vaccine. And then 2 weeks later, on Monday, this last Monday, October 6th, CDC accepted ACIP's recommendation for COVID-19 vaccine. Now, this would usually happen in 24 to 48 hours after the ACIP's recommendation, but it took 3 weeks, it took nearly 2 weeks. And Meanwhile, for the past 3 weeks, the Oregonians have been able to receive the COVID vaccine without the need of a prescription.
Can I ask?
Next slide.
So,
Oh, yeah.
all right, I think you've explained this once or twice already, but I'm still trying to understand what shared clinical decision-making means, like how that works. I mean, who's sharing decision-making with who?
Yeah, so that's based on it refers to the providers, including physicians, nurses, and pharmacists working closely with the patients to, yeah.
There's kind of a general federal guideline or recommendation, and then your clinical provider kind of helps you navigate that.
Correct. So on that note, let's look at the WCHA and the ACIP's official released recommendations. As I kind of touched on, the West Coast Health Alliance released their recommendations on 9/17, and this made it possible for Oregonians to receive their COVID-19 vaccine without the need of a prescription. Alliance members jointly announced that the recommendation that immunizations are safe and effective and offer the best protection available against respiratory viruses. And this recommendation also endorsed broad access to the COVID-19 vaccine for anyone who chooses protection. And now looking at the wording from the ACIP's recommendations from their September 18th and 19th meeting, individual decision-making was referred to on their adult and child immunization schedules as a vaccination that's based on this shared clinical decision-making, which references providers, including physicians, nurses, and pharmacists, as I just spoke with Commissioner Chang about. Yeah. So I know this is a lot of information, and it's been completely understandable why it's confusing for everyone surrounding this season's COVID vaccine. And although there's some very slight nuances to the recommendations for the COVID vaccine this year, I do want the takeaway to be that it's available now and it's without the need of a prescription. And I do recommend that if anyone's still confused about whether any of the respiratory season vaccines that we just touched on are confusing or they need help, I do always suggest talk to your provider.
So far, I'm getting RSV for youth, for babies, real young, and then COVID focus for 65 and over or complicated medical conditions. Is that generally the concept that? Because I mean, that's what I'm looking for. What's the general idea about what somebody should do? Because this isn't my world, but as a public health authority, we should be up to speed on this.
Yeah. I think what Commissioner Chang was saying too, that there are these general guidelines, and I think even in prior years, it's known with COVID-19 illness that the people at highest risk are those that are seniors, 65 and over, or anyone with health conditions. A lot of different, it could be immune suppression, it could be asthma, lung disease, et cetera. So we're most worried about that population. Same would be true with RSV, where the most severe illness is usually in kids, usually infants actually. But at the same time, we want to offer as much protection for the community as we possibly can. We realize these are very contagious viruses, especially the Omicron variants of COVID-19. And so sometimes healthier adults, in their 30s, 40s, might, unintentionally spread COVID-19 or influenza to, a more infirm family member or somebody at work who has health conditions.
Great, thank you.
That sort of gets at, I mean, one of the things I'd like to understand is, so for a few years we were in a pandemic, and now we're past pandemic. I mean, people would now call COVID an endemic disease. Is that the term you would use? And I'm trying to understand how we treat vaccination, how we think differently about vaccination when you're in a pandemic versus when you're in an endemic. Is COVID basically like the flu now? Or are we still? I mean, for the reasons that you were just describing, Dr. Fawcett, people in their 30s and 40s exposing more vulnerable populations to COVID if they get it. Yeah. Are the reasons why you would get vaccinated at this point, basically the same as the reasons you would get vaccinated for the flu? Or are we still trying to achieve the herd immunity during facing a pandemic?
I would say because it's tricky because COVID's not a seasonal disease yet. And so essentially, because of the way that the timeline goes for the agreement across, starting back at the beginning of the year for vaccines, the COVID just kind of got tied in with the flu vaccine. So when they're deciding on which strains they're going to cover based on, global surveillance, because, other parts of the globe, the Southern Hemisphere is just getting out of their, flu season, then we take that information and put that into our guidelines for how we're going to react to this upcoming season. So because it's such a process to make sure that the vaccines are chosen correctly, they're approved upon by the ACIP. ACIP makes its recommendations to the CDC, and then the FDA comes out with its on-label use guidance. All of that is such a process that the COVID vaccine got tied into that process so that things could happen in a timely manner. So having said that, it has kind of become along the lines that it's just more convenient and we have better uptake amongst our community if the COVID and the flu vaccines are offered at the same time. So what I will mention too is that it's still your choice whether, you want to get a COVID vaccine at the same time as your flu vaccine. And in our population that isn't immunocompromised, it's less, I don't want to make any broad sweeping statements here, but essentially we're heading into the holidays. And so if you're going to be with, someone in your family who's very young or very old, maybe it is the best choice for you to get a COVID vaccine this season because you're going to be traveling home. But then we do have people that are immunocompromised, and past guidelines have allowed immunocompromised people to get a COVID booster even as soon as 2 months, depending on their level of issues. So essentially, 2 months from severely immunocompromised people, are allowed to have a vaccine every 2 months. However, I'm using the 2024-25 guidelines. There's been no specifications this year for that at this point. But it generally, people who do suffer from some immunocompromising health issues have gotten it every 6 months. And so there was a little bit of some frantic, phone calls to us when we still at earlier September didn't have a COVID vaccine available in the community because they had timed it just so that they're coming up on 6 months of being due, and you can understand why they would be concerned and looking for their, updated booster.
Could one of you also talk a little bit about the severity of the disease if you get COVID? Looking at from variant to variant to variant over time. I mean, a lot of people died in the peak of the pandemic, and I'd like to understand whether that's because those were more dangerous variants or because there was just so many more people with COVID.
It's a great question. I think I like to emphasize, and I would do it again today, that the Omicron subvariants are very different in terms of how they behave in terms of severity in particular. So there's enough mutations in the Omicron variants where the disease is almost different than the original COVID-19, the Delta, Beta strains, Alpha, et cetera. So, the initial 1.5 to 2 years of the pandemic was really a different experience around the world. Now, I would say it was even a different experience after we had vaccines. So when we get to the end of 2020, beginning of 2021, when I had my vaccine, which was Pfizer, we were still dealing with the original strains. So severe illness, vascular complications, myocardial infarctions, heart attacks, strokes, respiratory failure. So that was a scarier, more difficult, challenging time for sure. Omicron again, it's still COVID-19, so it's still SARS-CoV-2, but it's got enough mutations that it doesn't really produce the same severity of symptoms. However, it's very contagious. It's very, very, very transmissible. And I think it's a challenge in more infirm type patients with more chronic medical illnesses, even if it's not immune suppression. So I hope that's helpful, that it's still something that's transmitted very easily in the community. We get spikes in test positivity rate very quickly. And we do see hospitalizations associated with COVID-19, where, I mean, before it was very clear they had typical respiratory failure with, lung pathology that was very typical of the original COVID-19 strains. We don't see that now, I mean, fortunately, but we still see folks that everything else gets worse, their heart failure and their diabetes, and they end up getting hospitalized. So it's a different clinical presentation than it used to be with these Omicron variants now.
Right. And I mean, the PCR tests that the data you displayed for us are based on, I mean, people are only getting PCR tests when they have symptoms that make them go in to see the doctor, right? So, I mean,
there's no question.
It's severe enough that a lot of people are going in and then testing positive for COVID.
No, I think that's right. I mean, you don't have to be in an emergency room to get a PCR test. There's all kinds of experiences, as you're mentioning. A lot of, I would say, in some seasons, months, probably half of the COVID-19 diagnoses are presumptive, because there's either somebody they know that had COVID-19 and they have similar symptoms, or they have a home rapid antigen test kit, which we don't have. We can't have. There's no way to track the rate of those tests. And some of those tests, have expired and are not always reliable, depending upon the kit that they bought at home. So there's more milder disease than we can demonstrate in these graphs, no question. We do have other data from emergency room visits for people with flu-like illness that's suspected to be COVID through what's called Essence. So we have some handle on spiking of disease that way, and with wastewater as well. And we look at that in conjunction with the PCR test positivity rate, and they kind of parallel each other. So we're missing a lot of milder disease, I think, in the data.
Yeah, I would add that's, I think, why we're excited in public health around wastewater, because people are doing tests at home or they're not going in. And it allows then our community, if we can really look at wastewater, to detect early, so then people can make informed decisions and choices for themselves. And so, in a couple more slides, we really want to kind of show the community ways to stay informed. And so if you have any more questions, I was hoping we could move along and show that.
Just to follow that, Dr. Fawcett, you said earlier that wastewater is paralleling the PCR test data, right? At least right now.
Locally, yeah.
Pretty well.
Yeah, I think other locales too, yeah. Yeah, it's exciting.
Maybe one more question about these Omicron variants. I mean, is it possible for those to mutate and produce a new variant that is much more dangerous and lethal?
I think that it is possible. I think historically speaking, that doesn't happen very often. Fortunately, I think, the data you have for Spanish flu, back in the beginning of the 20th century looked like that. It kind of burned out, but there was still milder disease. Other pandemics tend to do that as well. I think we saw that a little bit with H1N1 back in 2009. So historically, we feel like it, because it remains contagious. The virus wants to perpetuate itself and be able to infect more individuals, but it doesn't tend to get more virulent. And if that happened again, I think we'd be looking or wondering about SARS-CoV-2. So it's just not as common for that to happen. Yeah.
Okay. Thank you.
Great. Okay. Just a quick reminder about other non-vaccination strategies to minimize the spread of COVID-19 and other viruses, especially during the colder months. So good hand hygiene, washing of hands. And I think we're getting better with this. There's two things. There's often hand sanitizer available in public places. There's types of surfaces that are high-touch surfaces, so doors that you might come in through here, I suppose, when it's crowded, to just think about hand sanitizing or hand washing on a regular basis. Of course, just general manners, covering your cough and sneeze is important as well. I think too, when we're in crowded environments, so in an airport or crowded restaurants, to try to avoid very close contact, if it's, if you can. It's hard to do when you're going through TSA in an airport, for instance, but stay at home when you're sick. So if you're not feeling well, be responsible. Don't come. If you have to come, stay away from people and try to get home. We really encourage that. And I think if there's questions, this comes up with me a lot, where people, have a sort of a busy type occupation and are not sure if they're really sick or not. But contact your provider, discuss it. How contagious could I be? Are there contagious viruses circulating in the community right now? So if I go to work, I'm going to get my coworkers sick. So just some common sense things in addition to vaccination. This is just a summary slide. I won't really go into this for the sake of time. It outlines the West Coast Health Alliance and Oregon Health Authority recommendations for all three viruses as of a couple days ago and into the end of September. Looking at COVID-19, I think what was at issue was looking at the a little bit less vulnerable population, adults without conditions under 65 years of age. And the local consensus, at least through this alliance and now through ACIP as well, is that anyone who really desires a vaccine, a COVID-19 vaccine, should be able to have access to it without, without having to pay out of pocket. And so I think we've gotten behind that. ACIP has gotten behind that. The wording there about shared clinical decision-making is a little bit different than anybody who wants one, but it's very similar. And that's very much like what we did last year. And I think we had good success with our COVID-19 boosters last year.
A question. So the Advisory Committee on Immunization Practices, ACIP.
Yes.
Are we aligned now or not? I mean, because that was kind of the national news, and then it was the West Coast, and then.
Great question.
Yeah.
And you said, on Monday there was decisions made.
Yeah, so I guess the way I look at it, and Dr. Fawcett can add, is the ACIP, it's that shared clinical decision-making for all ages. They don't really specify any more detail than that. And then I would say what Oregon Health Authority has done, or the West Coast Health Alliance, is kind of further explain. So kind of to your question, Commissioner DeBone, around, okay, who is more at higher risk, right, for severe illness? And so that's kind of what this shows up here, is these are the higher risk populations who the West Coast Health Alliance, OHA, and we would recommend getting the vaccine because they're more likely to have severe outcomes. And then ultimately, it's everyone's decision and choice on whether they want
But just
to or
the
not.
ACIP decision on Monday kind of aligns with this. Is that that's what I'm picking?
Yeah, that's the total takeaway, is that in all, it's very similar. It's just worded differently.
Good.
Yeah.
Right.
Thank you.
So also, just as Heather had mentioned before, we do have ways for the public to just keep track of what's going on so they can see this themselves. There's the Central Oregon Weekly Flu Report. Links are provided showing people how they can stay in touch and receive a weekly flu report. And then more importantly, this is the more direct way to sign up for the Central Oregon Respiratory Report.
And that would be an email, weekly email?
You can go directly to the Deschutes County website. And there is a section there on the side for data and reports, and you can sign up.
Sign up for an email.
Yes, excuse me.
Just confirming
Yeah.
what the delivery is here, yeah.
Gotcha.
So at the last weekly flu report, how many people actually were positive then? The latest one you show here for March on our diagram. I'm just wondering, what is the latest number? We're into October?
For influenza?
Yes.
Yeah. Or no, I think for influenza, you're wondering what.
Right. I'm looking at that report and I just wondered, okay, so if 175 were positive March 3rd, how many are positive? Well, would it be last week's report we'd have?
Yeah, we had the data comes out Monday typically, so that was for the last.
Okay, so last week, Monday.
Right, and it's quite low. I mean,
Dr. Bacho might know current information.
So for COVID, it was 13%.
But you were asking.
No, I'm asking for numbers, though.
Very low. Yeah.
Mhm.
Flu was minimal, so less than 1%, and so was RSV, less than 1%.
Okay,
So both are still minimal, but COVID has been like kind of plateauing.
13%?
Correct,
COVID was
13%.
Yeah.
But what are the actual numbers then of the tests? I mean, was it, were 2,000 people testing and you got 13% of that? I mean, I'm just wondering how many people are walking around with COVID.
Yeah, I don't know the exact number, but
Okay.
yeah, we can get that to you later.
Okay, because percentages, only tell, like
Yeah,
this
but they were in
report
the
shows
thousands.
the numbers.
They were in the thousands.
Yeah, we can get you the most recent respiratory.
Okay.
Sign up, but I would also add that remember this is tip of the iceberg because this is only people who go in for a PCR test.
Okay, so what about the wastewater testing then? Where does that go? Those numbers?
That is also part of it, and we can definitely share that as well. Mhm.
Okay, because I mean, what's it saying?
But that
It's-
doesn't tell us individual case
It doesn't
numbers.
tell
It
you.
just says there's.
Well, no, it
there's-
knows when it goes.
There's a lot of COVID or a little bit of COVID in the wastewaters, right?
Right. Right, so yeah.
Yeah, so we can definitely share the respiratory report with you, and that has all the information. It also includes what's called our Essence data, which is looking at our emergency room visits for influenza-like illness or respiratory illness that people are being seen in the ER as well. That's all in that respiratory report.
Thanks.
Mhm.
COVID, as we've seen the last 3 years, has been increasing in the community since about mid to late August, and the peak was a little over 16%. It went down a little bit, but this last report, which was the week before, was about 13%. And I'll look at numbers. Hundreds of tests, sometimes 1,000. So we're talking about a fairly substantial amount of confirmed tests by PCR, and we are seeing it in the community. So I had a call this weekend from somebody who was looking for Paxlovid who was positive. So it's still circulating.
So are they still doing the monoclonal antibodies for people that are older with COVID?
That has not been recommended or practiced routinely for a little bit of time with the Omicron variants. What's that?
Said for 4 years then? Are you saying that they just dropped it?
I haven't seen it being given for at least a year to 2 years, maybe longer. Yeah. So, I mean, there's remdesivir that's being used sometimes for, it's IV only antiviral that works fairly well, but it's only for more severe illness and typically in the hospital. And there's still oral antivirals, mainly Paxlovid is what we use for milder illness. Yeah. Yeah, usually in people with conditions that might lead to complications. So it's not contraindicated in anyone, but it's favored in people who have medical conditions.
Thank you.
Okay.
Lastly, yeah, just our references down there. And we want to thank you guys for allowing us to come and hopefully not bore you to death on respiratory season vaccines. And I know Commissioner Chang has bared with my other presentation with the Public Health Authority Board. So
Yeah. Hearing similar information twice allows me to ask better questions.
Mhm. Yeah, there you go.
I can dig a little deeper.
Yeah.
I appreciate all the questions. Thank you.
Yeah, well, it's a great time to take a moment, and it's early October, think about the big picture. I still feel, in many layers of life and society, kind of echoes of COVID. The world's a little different now. But yeah, what's the big picture about just recommendations and best practices? So it's great to spend some time just even thinking about, what's appropriate actions or responses.
And I encourage people, because we do receive many phone calls to the county. I encourage people if they have any questions, because not everyone, especially our elderly population, they don't necessarily look to our website and follow links. And so we get a lot of phone calls, and I do encourage people if they have any questions and they find themselves, without a provider readily available, just give us a call. Okay.
Thank you so much.
Thank you.
Everyone. Thank you. So at this time, other items, if there's anything. As I said, I'm not bringing anything today, I don't think. Next few days.
Are we adjourning or?
But just other items, if anything. I see Commissioner Dare wanted to ask one more question individually there, but yeah, anything, Nick?
Sure, I'm happy to make an announcement, especially in light of the discussion we just had, and that I am so pleased to announce that we have a new Health Services Director, Holly Harris. We're taking the interim title off, and that was effective Monday. And I'll just share just a couple of quick comments. Holly's served as our Deschutes County Behavioral Health Director for nearly 3 years. And when we go into the Wayback Machine, she joined the county in 2013 as a behavioral health specialist. Played pivotal roles, as we all know and the community knows so well, in establishing the Stabilization Center and securing funding for the region's child psychiatric unit. The list really goes on for her extraordinary achievements, and it's such a big position. It's nearly a third of all county employees, so nearly 400, or about 400 of our nearly 1,200 or over 1,200 county employees. It's a big job, and I'm really, really pleased and thrilled that she's accepted the position to serve as our Health Services Director.
Well, great. Thanks for bringing that up at our public board meeting, because yeah, we've been involved with recruitment, sitting down, doing interviews, email went out. So sometimes you forget, oh yeah, this is the board meeting where we're telling the world. So, but yeah, congratulations to Holly Harris and the organization. Let's move forward. It's exciting to have the camaraderie and the willingness to serve the people. And Holly's definitely going to be a good person in that role.
I mean, I'll also say that, we did a couple of external recruitments, and it is really helpful to consider people from outside to bring a fresh perspective. But in this case, our health services department is incredibly complex. It's complex. It's complex. They're pioneers in so many ways in the state, and it's really important to have someone in that office who, from day one, recognizes that complexity, recognizes the innovation role we play in the state of Oregon, and it's especially valuable to have someone like Holly who comes from within, from that perspective, to keep those two things moving. So, many thanks to Holly for serving in this role.
Thank you. So this is other items, and Nick brought it up.
I just wanted to say, yes, thank you, Holly, for really contemplating, spending a lot of time, and then actually, applying for the position. So yes, definitely, she's a great choice, and I'm really looking forward to working with her. And I'm hoping we can do our pilot program on getting our schools with a much, much healthier lunch menu. And I guess they serve breakfast too. So yeah, I think there's a lot of opportunities to get our kids a lot healthier.
I think there's some real, if you're really interested in that, there's some real opportunities to advocate to the federal government, because a lot of the nutrition that is provided at schools is really shaped by federal policies and what the federal government offers to schools, and encourages schools to use, what they subsidize. So we can ask our health services department to look into that, but really I think a more useful thing would be to be talking to the USDA and members of Congress.
Thank you.
So one other note, joint meeting with the City of La Pine tonight, 5 o'clock at the La Pine City Council Chambers. The Board of Commissioners will be there. Anything else for this meeting? Seeing none, meeting adjourned.